Dr. Benjamin Honton from Clinique Pasteur in Toulouse, and I will be joined by full-star IVL experts in the name of Dr. Ziad from the San Francisco and Earth Hospital in New York, USA, with Professor Carlo Di Mario from the Carnegie University in Florence, Italy, and with Jonathan Hill from the Royal Brompton Hospital in London, UK. Thank you so much, gentlemen, to be with us today and sharing your knowledge. We have the chance to have the Professor James Pratt as a moderator, and he will be the connection between the community and our expert today. So all of our experts have been involved in the field of IVL from the beginning to the latest evidence in this rising wave. So if you want to dive inside the latest insight of IVL, you are at the right place at the right time. And the symposium will be building as the following. Dr. Ziad will give us insight on the unique mechanism of IVL and all the basis of engineering that we need to know for the best use of IVL in our daily practice. Professor Di Mario will give us a second talk on the latest clinical data with the results of the pool analysis of the trials on the Disrupt Clinical program, which have been recently published. And finally, Jonathan Hill will give us insights on what we learn from intracoronary imaging with the analysis in CAT 3. It will be the connection for a 10 minutes live question and answer. So please feel free to send all the burning questions on the live chat that you had and you want to raise with the experts. But ladies and gentlemen, time is running out. So let's start to surf on this wave with the first presentation of Dr. Ziad on mechanism of intravascular lithotripsy.
Hello, everyone. My name is Ziad Ali from St. Francis Hospital and Heart Center and the Cardiovascular Research Foundation. And today I'm going to be talking to you about the principles of IVL and its unique mechanism of action. These are my disclosures. Somewhere back in 2009, on a Sunday evening in an hourly rental lab in Mountain View, California, we did some of the first experiments investigating whether IVL may have any utility in interventional cardiology. These are eggs that were bought either from a Safeway, a local grocery store, or from John Adams, the brainchild of Shockwave's Wrench, filmed using an iPhone 1. And what you'll see is we've basically put together a lithotripter, and some of the things that we heard during this video was it's doing something. Looks like it blew a hole in the backside that we're seeing on the front side is the membrane, and I think this is going to work. Anytime you're doing any device development, if you hear the term, I think this is going to work, that's generally a good thing. One of the key images is actually here on the right side, where you see the lithotripter. We drilled a small hole to get the lithotripter inside of the egg, and it's blown away the outer shell of the egg, but the membrane is completely intact on the inside. This was, in fact, the eureka moment. And some 11 years later, Shockwave intravascular lithotripsy has been finely refined using a mechanism by which expanding and collapsing vapor bubbles create these short bursts of acoustic pressure waves. These acoustic pressure waves travel through the vessel effectively with approximately 50 atmospheres of pressure. But there's a unique feature of this 50 atmospheres, which I'm going to talk to you about a little bit later on. This creates a localized field effect within the vessel, and it fractures both superficial and deep calcium. Now, to understand the mechanism of action of intravascular lithotripsy, you need to understand a little bit about extracorporeal shockwave lithotripsy, ones used for renal stones, which have been used for a long time, on which coronary and peripheral IVL is adapted. Essentially, what you have on the left panel is a spark plug, and that spark plug basically creates an electric pulse between two electrodes and creates an arc. And the energy from that arc goes from being unfocused to focused using a parabole. And what that means is something like a flashlight. If you look on the inside of a flashlight, there's all those mirrors. those mirrors focus unfocused light so that you can get a beam. And by focusing this energy, you can get a sudden burst of energy, which you see on the right-sided graph, with a very short rise time, a sudden increase in pressure, and this is followed by secondary waves, which actually have a negative tensile strength, and then finally a secondary rise. Now, there are many mechanisms by which intravascular lithotripsy creates fractures. The most predominant one is actually the compressive stress, which is released as the shock wave expands and collapses and releases the energy, which squeezes the stone or squeezes the calcium. Subsequently, the shear stress goes through the calcium as it propagates and creates small jets, which actually lead to further fracture. Spall stress, which is the reflection at the end of the calcium, actually is a wave reflection that pulls the calcium in. Finally, there's tensile stress, which leads to cavitation, which causes microjets, sudden bursts of these jets, which cause these small microfractures. And finally, there's an impedance difference from the outside soft tissue and the inside of the calcium, which is hard, which leads to a squeezing effect. Taken together, these lead to calcium fracture. And used clinically, intravascular lithotripsy, we inflate a balloon at 4 atmospheres. This creates this vapor bubble, which leads to those compressive forces, followed by the Spall stress and the shear stress that impacts the calcium, fracturing it and improving vascular compliance at 6 atmospheres. Now, there are a few fundamental differences between extracorporeal shockwave lithotripsy and intravascular lithotripsy, and they're highlighted here on this graph on the left. The most fundamental difference is you'll see the blue line, which is the intravascular lithotripsy, is actually magnitudes lower energy than extracorporeal shockwave lithotripsy. And why that might seem a little bit counterintuitive, in fact, this is what allows the safety of IVL. Because if we had very, very high energies, it could pulverize the calcium and actually cause coronary perforation. And if we look over here on the right side, what you'll notice is that the fundamental differences between extracorporeal shockwave lithotripsy is that in IVL, the energy is much lower and unfocused. The peak positive pressure is approximately 50 atmospheres. The negative or peak negative acoustic pressure is 3 atmospheres. That's important because that's the Spall stress, which is pulling the calcium from the edge of the adventitia. So you don't want it to pull the adventitia in and create a perforation. The depth is approximately 3 to 7 millimeters, so it can impact superficial and deep calcium, but not impact, for example, bones. And the predominant mechanism of action is, in fact, compression stress. Now, another important mechanism of action is pulse management, whereby you'll see that the optimal sizing of the balloon is very, very critical. And what happens in this optimal sizing is that the balloon should be 1.1 to 1 ratio against the artery, because the larger the balloon, the greater the field effect. In fact, if you have an undersized balloon, which is in poor contact or sort of floating within the artery, much of the energy from the IVL is actually dissipated within the liquid interface against the wall. Finally, what's critical is to understand the spatial differences of the different IVL catheters, because the maximum amount of energy comes completely circumferential or perpendicular to the electrode itself. And here at the bottom, you can see when you use optimal technique compared to suboptimal technique, there's a significantly better clinical outcome. Now, as I mentioned before, there are subtle differences between the different catheters used for the coronary, below the knee, and above the knee. And what this really has to do with is the number of channels that transmit the energy to the wall. Here in the coronary, you see 2 channels, which are diametrically opposing pairs. They're 180 degrees from each other. So the energy is focused in one direction, in one electrode, and the other in the other, but radiates in a circumferential manner. What you'll also notice is that the maximum amount of energy is immediately perpendicular to the electrode. Here on the M5, you'll notice that there's one field effect which is considerably larger than the others. And the reason for this is because this channel in the middle of the M5 gets its own wire. And as a result, the atmospheric pressure that's generated by this electrode is almost double that of the other electrodes, which have to split the channel and thus the energy. The fundamental details of the M5, S4, and C2 catheter, including their sheath compatibility, working length, and crossing profiles, are displayed here in the table. Now, ultimately, what happens is the mechanism of action creates a single pulse, and actually, as this acoustic pressure wave collapses and creates a cavitation bubble, that cavitation bubble collapsing releases that compressive force, which is the predominant mechanism of action for fracture. There are important features to understand about the coronary balloon, and that is from the end of the balloon or the radiopaque marker, the first electrode or emitter is 2 millimeters in. Then there's a 6 millimeter gap, followed by another 2 millimeter gap, and finally the final radiopaque marker. So the spaces between these markers are 4 millimeters to the first electrode, 6 millimeters to the second electrode, and 2 millimeters to the radiopaque marker. And what that does is it really provides an important mechanism of action for intravascular lithotripsy. And that is that IVL is hard on hard and soft on soft. And this is because of the differences in the impedance properties of tissues. The impedance property of fat or muscle or soft tissue is very, very similar to water. But hard tissue, bone or calcium, is orders of magnitude, maybe 8 to 10-fold higher than that of soft tissue. And so ultimately what you end up with is this type of mechanism. On the left side, you have IVL, which is like a karate chop. And on the right side, what you have is a high pressure balloon, whereby it's a long sustained pressure which does not have the same sudden burst impact on being able to fracture calcium. And what you'll also notice is that there are multiple planes within which calcium fracture occurs, not simply the ones that we're used to seeing on OCT. Here in this micro CT, what you'll notice is that while there are indeed longitudinal fractures, you also see what look like calcium chips. And this is because some of the other stresses that I showed earlier, such as the shear stresses and such as the tensile stresses, which can lead to these microjets, which can lead to smaller chips of calcium, which nonetheless can improve vascular compliance. But this is what we're used to seeing. We're used to seeing these circumferential calcium fractures on OCT, which lead to an increase in luminal gain in a dramatic fashion. And here in this example, what you'll see in this data, which shows that pre-procedure compared to post-IVL, there's a significant gain in the minimal lumen area. And what that does is actually lead to a fracture, which can then be further expanded by the stent, which ends up holding this space open, which ultimately fills with fibrous tissue. And that's what allows the very large increase in luminal gain. We showed in Disrupt CAD 1 and 2 OCT sub-studies that the more the calcium, the greater the number of fractures and the greater the efficacy of the IVL on stent expansion. More recently, Richard Schlafmitz showed in the Disrupt CAD 3 OCT sub-study that in fact, even those vessels which didn't have as much fractures, there was still an excellent expansion, suggesting that some of these other mechanisms, such as the chips, may be inducing or augmenting lesion preparation and vascular compliance. So the components of the Shockwave IVL are simple. It's essentially a balloon connected via catheter, which connects to a console. The console is battery powered and creates the energy, and a simple push button delivers the energy at 1 hertz for a maximum of 80 pulses in the coronary circulation. Another advantage, of course, is that the IVL does not require side branch protection. You can leave a wire in the side branch if you want, and it's compatible with any guide wire with just slightly larger crossing profile than a non-compliant balloon. So in summary, IVL utilizes electrical energy to generate acoustic pressure waves which impact calcium. The acoustic pressure impacts calcium by multiple mechanisms, and compared to ESWL and ISWL, IVL energy is lower, in keeping with its goal to fracture but not pulverize calcium. Adequate balloon size is critical to effective IVL, substantiating the utility of intravascular imaging in calcium. Understanding the spatial placement and separation of the IVL electrodes can help with case and pulse management. The mechanism of calcium fracture is an acoustic pulse, which is short and sharp, and in vitro and in vivo studies confirm calcium fracture as the mechanism of this improved compliance. And as such, IVL is certainly going to be an important tool in the modification of coronary artery calcium. Thank you very much for your time, and enjoy EuroPCR 2021.
Good afternoon. Thank you for giving me the opportunity to present the data from this pool analysis that includes two studies, CAD 1 and 2, of which I was top enroller and principal investigators. I have, first of all, to indicate my disclosure. The most important are the research grants given to my hospitals, both in London and in Florence, by Shockwave Medical for these two studies. These data have been presented just 2 days ago at ACC 2021 by Robert Reilly, and I'm going to report the patient-level pool analysis of all 4 the Disrupt Cad studies that include 628 patients enrolled in 72 different hospitals across 12 countries. These analyses benefits from the uniformity of the study protocols. That means that the primary safety and effectiveness endpoint were the same for all the 4 studies, being defined as MACE, cardiac death, MI, and target vessel revascularization for the safety endpoint, and successful stent delivery with a residual stenosis of less than 30% without in-hospital MACE for the effectiveness endpoint of procedural success. With this number, we were able also to run a multivariate analysis of predictor of MACE and success. These are the characteristics of the 4 studies, starting from the very first implantation in Australia and London in 2015, early 16, to the most recently concluded trials, CAD 3, the largest of these 4, US and Europe, has been concluded and reported in September at TCT last year. All these were prospective, multi-center, single-arm registries. They all had monitored data and adjudicated events, and the definition were the same. Probably the most controversial in a way, very variable from trial to trial, that I think we should highlight is the fact we use as definition of peri-procedural MI a rise of CKMB greater than 3 times, with or without pathologic Q waves. Target lesion had to be severely calcified, and this was defined as presence of radiopacity on both sides of the vessel for more than 15 millimeters in length by angiography, or the presence by intravascular imaging or CT or IBUS, or a calcium angle greater than 270 degrees. The vessels included had to be between 2.5 and 4 millimeter balloon. Total occlusion were excluded. The maximal length of the lesion had to be within 32 millimeter for the first 2 trials, and this was increased to 40 millimeter for CAD 3 and CAD 4. So not the easiest lesions, and this explains why patient has somewhat more complex characteristics than the one we normally treat in our cath lab, older, 72 years of age, and with factors that are increasing the chances of calcified stenosis, diabetes mellitus 38%, renal failure 25%. These are core lab adjudicated angiographic characteristics. As you can see, the artery that was most frequently treated was the LAD with 59%, very few protective main at 1.4%. And it's important that the core lab confirmed the presence of severe angiographic calcification or intravascular imaging adjudicated calcification in 97% of the cases. Bifurcations with Medina 111 were excluded by definition, but 30% of cases had one branch greater or equal than 2.5 millimeter rising from the treated segment. These complex lesions were treated in a reasonable time of 64 minutes using in 2/3 of cases the conventional approach that we prefer because of the reduction of risk of bleeding and other events. Radial approach. Pre-dilatation before insertion of the IVL catheter was used roughly in half of the cases, 1.3 catheters per patient, 80 pulses were delivered with the balloon inflated at low pressure, 4 to 6 atmospheres. After lithotripsy, rarely was needed additional dilatation before stent implantation. You see the stent could be delivered in all cases, 99.5% of cases, with post-dilatation consistently performed in 94% of cases. Diameter stenosis was reduced from the pre-procedural 63.7% to post-lithotripsy 35.4% to a low percentage of residual stenosis of 12.1% at the end of the final stent expansion. And these are the corresponding changes in the minimal luminal diameter. Again, core lab adjudicated angiographic complications. You see that after lithotripsy, you had 1.8% only of flow-limiting type DF dissections, 0.4 slow flow, and the flow was restored after stent implantation. There were no perforations or abrupt closures after lithotripsy, 0.2% after stent implantation, resolved with cover stents, and you see 0% slow flow or no reflow at the end of the procedure. Primary safety endpoint at 30 days, you see here a consistent safety, 7.3%, the pooled level, very similar in the 4 studies that tell us that probably this technology is easy enough. It's just at the end of the day, a bulky balloon to be inserted, not to pay a price in terms of poor results due to the learning curve. These are the in-hospital and 30-day MACE. As expected, the vast majority of the events were related to non-Q wave myocardial infarction, CK leaks, relatively benign complication. You see very few cardiac deaths in hospital or at 30 days. The safety endpoint procedural success was again consistent across all 4 studies. So ability to implant the stent, a less than 30% residual diameter stenosis without MACE was achieved in 92.4%, very similar in the 4 studies. The secondary endpoint at 30 days, 1% target lesion revascularization, 0.8% stent thrombosis, in line with what you expect for normal reason, not extremely severe long calcified lesion as the one that we are treating in this trial with second generation drug-eluting stents. Predictors by multivariate analysis of MACE was the presence of a side branch at the site of the calcified lesion treated, increasing the risk by a 2.4 odds ratio, prior MI doubling the risk. Per each millimeter of increase of lesion length, we have an odds ratio of 1.3 to have a greater number of MACE. Procedural success was reduced in the presence of bifurcational lesion or prior myocardial infarction. 30-day MACE subgroup analysis, we didn't see differences in terms of age, in terms of sex, in terms of presence of diabetes or renal failure, of a previous CABG, according to the size of the vessel. The only difference that we found concerned the presence of lesion length greater than 25 millimeter and presence of bifurcational lesions, increasing the risk of MACE. For procedural success, same story, no difference across all subgroups with exception a borderline significant of lesion length and bifurcational lesion. In conclusion, the Disrupt Cad pool analysis is so far the largest study of application of this new technology, intravascular lithotripsy, for de novo calcified coronary lesions before stent implantation. Our pooled outcomes demonstrate excellent acute safety and effectiveness in a complex calcified lesion subset. Consistent outcomes were achieved across the trials, and there is no evidence of a learning curve of a first user experience decreasing success. Subgroup analysis demonstrated again consistent results of lithotripsy treatment before stent implantation in these high-risk patients and complex lesion cohorts, and consistent with prior PCI studies, presence of bifurcation of a previous myocardial infarction and of longer lesion lengths were independent predictors of increased MACE and lower procedural success. Thank you.
Hello, my name is Jonathan Hill. I'm from the Royal Brompton Hospital. I'm going to be presenting the OCT sub-analysis from the Disrupt Cad 3 study. These are my conflicts of interest. The Disrupt Cad 3 program was part of the Disrupt series of studies, all of which had an OCT sub-study. In Disrupt Cad 1, there were 31 patients. In Disrupt Cad 2, 47 patients. And in CAD 3, there were 100 patients included in the sub-study, with participation from both the US and from the EU. In the Disrupt CAD 1 and 2 OCT sub-studies, there was a clear demonstration that IVL was able to induce cracks which were visible on OCT, with cracks extending from the intimal surface through the media. So in other words, full thickness cracks extending in a circumferential fashion longitudinally along the vessel. And the hypothesis was that this is the clear mechanism of action. The Disrupt CAD 3 OCT sub-study was designed to study this phenomenon in more detail. So the objective was to understand the mechanism of IVL for the treatment of de novo heavily calcified coronary lesions prior to stent placement using OCT. OCT imaging was carried out before the procedure. The IVL treatment was then carried out, and immediately following IVL, another OCT study was carried out. Stent delivery was then carried out, and following stent optimization, post-stent delivery was then examined using OCT, so a third study. So within this lesion subset, the reference vessel diameter was 2.5 millimeters to 4 millimeters with a stenosis of more than 50% and a long length of calcification less than 40 millimeters. And patients were enrolled beginning in January 2019 to just prior to the lockdown in March 2020. The ITT population for the whole study was 384, and there were 100 patients included in the OCT sub-study. Here you see the baseline characteristics of the patients in the OCT sub-study compared with the non-OCT patients. So there were no substantial differences between the two groups. And here we see the angiographic characteristics. So a preponderance of left mainstem lesions with just over 50% seen in the non-OCT group. The reference vessel diameter, MLD, diameter stenoses were all roughly similar. The procedural characteristics were also similar. It is interesting to note that there appeared to be a slightly lower total procedural time, not statistically significant, but it's numerically lower number of minutes spent with the OCT study compared to the non-OCT studied patients. And here we see images from one of the CAD3 patients. So assessing the angiographic core lab, the reference vessel diameter in this case was 3 millimeters, with a lesion length of 12.6 millimeters, with a diameter stenosis judged angiographically of just over 50%. The OCT core lab assessed this lesion with an MLA of 3.3 millimeters squared, with an area stenosis of 70.6% and a maximum calcium angle at this tightest part of the vessel of 360 degrees. So in other words, circumferential calcium with a thickness of over 1 millimeter. So the important characteristics that are assessed by OCT, in particular to assess the calcium burden, are to measure the arc of calcium, more than 180, the depth of the calcium, and the length of the calcium. And here we see, again, with this angiographic core lab, that with the balloon and the shockwave energy delivery, we end up with an acute gain of 1.15 millimeters with a residual diameter stenosis of 17.1%. There is a significant increase in the MLA up to 5.8 millimeters squared with an area gain of 2.5 millimeters squared. And there are multiple calcium fractures have been observed along the length of this vessel that has been treated with IVL. And here you see, following stent implantation, the in-stent diameter stenosis is 7.2% with an acute gain of 1.18. The MSA, so the final minimum stent area, is 8.7 millimeters squared. So a further increase from the post-IVL to the post-stent insertion. So stent expansion at the maximum calcified site was 79%. So satisfactory stent expansion in this case. With the serial OCT measurements, we saw an increase in the minimum luminal area pre-IVL to post-IVL, and then from post-IVL to post-stent, with a significant reduction in the overall area of stenosis from pre-IVL, post-IVL, and then following stent implantation. The calcium angle in the majority of these patients was significant, so more than 270 degrees, with a thickness approaching 1 millimeter, so a very heavy calcium burden. And the post-stent expansion was very satisfactory, just over 100%, with a minimum stent area of 6.5. And here we see the luminal area gain from pre-procedure, post-IVL to post-stent. So you see a substantial increase in the luminal area between the pre-IVL and the post-IVL picture. So there is substantial lesion expansion because of the mechanism of action here is that calcium is fractured from the intimal layer through to the media, and there is circumferential expansion with the balloon expansion of the IVL balloon. And then following the stent expansion, further stent apposition and expansion. Looking at the calcium fracture characteristics, we see in this panel on the left, no fracture, one fracture, or multiple fractures. And here you see post-IVL and post-stent, so no substantial differences there. And as you'd expect, there's no difference in the fracture depth. But what you do see is a substantial increase in the fracture width before stents are implanted, but after IVL, the fractures then expand. And the distance between the edges of the calcium fracture, they move apart like the tectonic plates moving apart, and there is a stent allowing stent expansion. So calcium fracture was observed in 67% of lesions post-IVL, with the minimal angle at the fracture site was 192, with a significant increase in the fracture width post-stent. Calcium microfractures may occur, which are beyond the limits of visualization. And in fact, what we saw with post-stent fracture and no fracture, there was no significant difference in the MSA, no difference in the stent expansion, and no substantial difference in the area stenosis. So in other words, there were consistent outcomes regardless of fracture visualization by OCT. Why does this happen? Well, it's likely because there are microfractures occurring beyond the resolution of IVUS and OCT. And here you see from these cadaveric specimens, so this is micro CT, you can see these very, very fine lines, which in fact, when you see them on micro CT, are too small to see with the naked eye. You can't see these on OCT, but you can see them with micro CT. So looking at the performance and safety outcome with OCT, we see 100% device crossing success, and in fact, an extremely low rate, in fact, no dissections, no perforations, no abrupt closure, no slow flow, and no reflow in the OCT-treated patients. So in conclusion, OCT confirmed the safety of coronary IVL with no severe angiographic complications at the end of the procedure. OCT demonstrated longitudinal and circumferential calcium fractures in heavily calcified lesions, resulting in increased vessel compliance, large post-procedural MSA, and excellent stent expansion. The MSA, area stenosis, and stent expansion outcomes were excellent regardless of calcium fracture visualization by OCT. This may represent a limitation of OCT to detect subtle micro fractures or out-of-plane fractures in calcified plaque. Thank you for your attention.
Thank you, gentlemen. We are very late, so few questions and quick answers. Please, Ziad, can you just highlight us how you treat eccentric lesion with your knowledge of engineering?
Great question. So I think, as Jonathan showed quite nicely, the more the calcium, the better the IVL works. So what you can expect in an eccentric lesion is to basically have half of the field effect. So it still works, but it may work as a concert, as a balloon, as well as a lithotripsy technology. So you may accept some dissections at the edges of the calcium and expect that you will have less fractures.
Great. Thank you so much. Professor Di Maio, thank you for sharing the latest clinical data. If you have to give us a key message from this pool study, what would be?
I think to answer your question, consistency is what surprised me. I've seen many new devices. Most of the times you go through a learning curve. So the first trial is often with ambiguous outcome, while here all the 4 trials consistently show the same excellent safety and efficacy. So it's an easy device to use, essentially, despite its great efficacy.
Yeah, it's a very important point. It's very safe. Jonathan, you have a huge experience. What do you learn from OCT? Do you think there is a parameter who can predict on the calcium on OCT what would be the IVL efficiency?
Yes, well, I think the way in which we're using OCT to assess lesion morphology is really the key to understanding the mechanism of IVL. So lesions which I think are the prototypical ideal lesion are the ones with thick calcium, more than 0.5 millimeters, and with near circumferential, so more than 180s, so more than 270 degrees of concentricity. I think that the perfect lesion is a 360 degree ring with more than 0.5 mils of calcium thickness. That's where I think we absolutely see the sweet spot of IVL. However, I don't think that when you identify an eccentric lesion with calcium, that we should be ignoring that and ignoring the use of IVL. So I actually think IVL is a technique for eccentric, concentric, thick calcium, and calcium thickness rather than concentricity is probably the main thing we should be looking for. Thank you so much, friends. There is so much question coming from the floor. Fortunately, Professor James Pratt have answered at most of the question. There is so much things to know and learn. And so I want to thank you for your involvement in EuroPCR. Its time is running out and we have to leave the session. So again, a great thank you for sharing your knowledge with us. Thank you so much.